Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 33rd episode of Optometry series. The topic for today is Idiopathic Intracranial Hypertension. I'm very happy to welcome my team members, Ms. Meenakshi and Ms. Anshika ma'am. Hi, Anshika ma'am.
Hi, Gopi. Hi, Meenakshi.
Hi, ma'am. So, yes, ma'am, please let us know. So, why today is this topic and what is the special thing about today?
So today, actually, it's an optometry series. Is we are going to understand this concept of idiopathic intracranial hypertension in terms with a case. This particular disease comes with a lot of symptoms which can be picked up by optoms very well, and it has become very common nowadays because we are all in that age of having junk food and becoming obese, and also when we read all that, we'll get to know, when we know about today's presentation, we'll know why this particular disease is important for us to know. So let's move on and learn more about IIH.
Yes, the MC for today is Ms. Rajini Priya. Yes, Rajini Priya. So let us know about today's presenter.
Good evening, all. I extend a warm welcome to each of you to today's enlightening session. My name is Rajni Priya, currently pursuing my third year, Bachelor's in Optometry at Dr. Agarwal's Institute of Optometry. The topic for today is Idiopathic Intracranial Hypertension with a case study. Today's presenter is Ms. Sandhya, pursuing second year, Masters in Optometry at Dr. Agarwal's Institute of Optometry. Following with Sandhya's presentation, Ms. Meenakshi, a faculty member, a pivotal figure in our optometry series, will share her valuable insights on the topic. Ms. Sandhya, without further ado, I invite you to commence your presentation and illuminate us with your knowledge on idiopathic intracranial hypertension. I once again thank you all for being here, and let's delve into this enriching learning experience together. Thank you.
Thank you, Rajini Priya. Yes, Sandhya, please start your presentation.
So today's topic is idiopathic intracranial hypertension. So idiopathic intracranial hypertension is characterized by elevated intracranial pressure, which is also known as by another name pseudotumor cerebrae, and also known as benign intracranial hypertension. So the idiopathic intracranial hypertension majorly affects overweight women of childbearing age. We can call them as obese women. So who are all the suspects of idiopathic intracranial hypertension? The CSF greater than 200 mm of water in a non-obese patient is a suspect of idiopathic intracranial hypertension, and in obese patient, the CSF greater than 250 mm of water is a suspect of idiopathic intracranial hypertension. So the epidemiology of idiopathic intracranial hypertension. So it is increasing in an incident with the current epidemic of obesity. So as we've seen before, the idiopathic intracranial hypertension mostly affects the obese women. So the annual incidence in all women aged 15 to 44 is 3.5 in 1 lakh, and the annual incidence of PTC, which is nothing but a pseudotumor cerebrae, the another name of intracranial hypertension, in general population is 0.9 per 1 lakh. So the positive correlation occurs between the female population and body mass index and PTC, which is pseudotumor cerebrae. So it majorly affects the 90% of the women of childbearing age, and these 10% of the patients are asymptomatic. So the pathophysiology of idiopathic intracranial hypertension is of three, which is vascular, cellular, and hormonal. Let's see each in detail. The vascular changes, it is likely to be the secondary to increased pressure rather than the cause of CSF increased pressure. So it is a secondary thing, but it will not majorly cause the CSF pressure. The hormonal changes, which leads to the increased CSF production. The hormonal changes includes aldosterone excess, which commonly correlates with PTC and is suggested to affect the mineralocorticoid receptor of choroid plexus, which leading to the increased CSF. The cellular changes, changes include increased outflow resistance to CSF, which is the major pathophysiology of idiopathic intracranial hypertension. The outflow resistance could be due to an effect on estrogen or retinoic acid, both elevated by increased adiposity on epithelial cells, leading to less outflow of CSF. The pathophysiology of CSF is vascular, which is secondary to cause the increased pressure, and hormonal changes will cause the increased CSF protection, and cellular changes will have resistance to CSF outflow. So let's get into the symptoms. Symptoms are headache, transient vision loss, diplopia, photopsia, and persistent vision loss. So the signs of idiopathic intracranial hypertension is papilledema, cranial sixth nerve palsy or lateral rectus palsy, and visual field loss. Let's see each symptoms and signs in detail. First, we'll get into headache. Headaches are 98% of headaches occurs in idiopathic intracranial hypertension. The IIH-related headache is defined in a headache classification of International Headache Society as ICHD3. So the presence of headache is common in patients with idiopathic intracranial hypertension and is usually presenting symptoms. So the more common symptoms of idiopathic intracranial hypertension is headache, and it occurs in 19% of cases. The headache is often not only reported as a headache, it is also associated with head pain, neck pain, and back pain. So it can be of any location, that is bilateral, frontal, or retrobulbar, often daily, sometimes associated with increased severity in the morning. So this headache symptom is also associated with mostly nausea and lessly with vomiting and photopsia. So as I said before, the headache will not only be a headache, and it will be associated with the head pain, severe head pain, and neck pain. So the next is a visual symptoms, which is transient visual obscuration and vision loss. So what is transient visual obscuration? The transient vision obscuration or short, lasting seconds to minute, and characterized by monocular or binocular fogginess, black, white or gray out, usually triggered by head or eye movement. So when the idiopathic intracranial hypertension patients have when they move their eyes, or they will feel this transient visual obscuration, and some patients report episodic brief visual sparks or flashes distinct from visual migraine aura. Position and gaze evoked symptoms are thought to be originate from ischemia of optic nerve induced by movement of swollen optic nerve. So the transient vision loss may occur during the eye movements, and the gaze evoked symptoms may occur due to the swollen optic nerve head. So this is one of the common symptoms of idiopathic intracranial hypertension, which is pulsatile tinnitus. So it is nothing but a unilateral or bilateral whooshing, whistling, humming, marching noise or heartbeat, which is due to the turbulent pulsating flow in intracranial vessels. As we know, idiopathic intracranial hypertension is due to the elevated level of intracranial pressure. So the pulsatile tinnitus is due to the turbulent pulsatile flow in intracranial vessels. It is not specific for intracranial hypertension alone. So it can occur in vascular abnormalities also, which are arteriovenous malformation, arterial stenosis, arterial aneurysm, and other benign causes. So let's come to optic nerve changes in intracranial hypertension. The major optic nerve changes which occurs in intracranial hypertension is optic disc edema, which is a bilateral optic disc edema. Then we will call it as a papilledema. So it is more common more common sign which is seen during the fundus examination. The observation of this finding either incidentally or in a patient with otherwise unexplained headache should prompt an urgent diagnostic evaluation. So in a chronic untreated cases of optic dysedema or papilledema can be replaced by optic atrophy due to damage to the retinal ganglion cells. Okay, so let's get into the grades of papilledema. In the first picture, we can see a C-shaped halo with a temporal gap, which is a grade 1 papilledema. And in grade 2, we can see a papilledema, the halo becomes circumferential. The grade 3 papilledema is characterized by a major loss of major vessels as they leave the disc. We can see in the picture. And grade 5 and grade 4, we can see a partial or total obscuration of all vessels from the disc. These are the 5 grades of papilledema. So how the neuroimaging will look like in intracranial idiopathic hypertension. So the major imaging techniques are MRI and CT, which shows globe flattening or optic nerve protrusion into the vitreous, optic nerve widening with increased CS of space in the optic nerve sheet, empty cella, and transverse venous sinus changes. So we'll see with an example. As you can see in the first picture, the high intracranial pressure, we can see a protrusion of optic nerve into the vitreous. So this is a case of intracranial hypertension. And in the second picture, we can see the image with the normal intracranial pressure. We don't see any protrusion or we don't see any papilledema. As in the first picture, we can see papilledema with protrusion in vitreous, optic nerve protrusion in vitreous. Next comes the visual field defect. So as we know, the idiopathic intracranial hypertension sign is a papilledema. The patient with papilledema will have a physiological enlargement of blind spot. So mostly this affects the peripheral visual field rather than the central visual field. Peripheral visual field, more common pattern of visual loss in intracranial idiopathic intracranial hypertension, and which develops from your optic nerve dysfunction related to compression by high CS of pressure in an optic nerve sheath associated with papilledema. So the earliest changes are seen in the inferior nasal periphery. So the prominent visual field defect as we seen in idiopathic intracranial hypertension is enlargement of blind spot. So as I said before, the central visual field are less affected. So it is not affected until there is an advanced optic nerve dysfunction and peripheral visual loss encroaches on field, as there is a tracking of subretinal fluid from the swollen optic nerve to the fovea. So we should also be we should also be aware of the high false positive responses and high false negative responses or fixation error. This is a flow chart with how the enlargement of blind spot, where it occurs. So in a case of papilledema, as we can, optic disc swelling with the blind spot enlargement in papilledema, and optic disc swelling inadequate to explain blind spot enlargement. This is a flow chart example for enlarged blind spot. So this is another perimetry image for enlarged blind spot, and how we manage the idiopathic intracranial hypertension. So there are two types of managements are there, which is medical and surgical technique. So let's get into medical treatment. Diagnostic lumbar puncture. So this diagnostic lumbar puncture mostly help the patient with headache. So it can transiently relieve symptoms or in some cases lead to complete resolution. So this is one method which gives a relief with the patient have a severe headache and weight loss. As we seen before, the idiopathic intracranial hypertension occurs in overweight women of childbearing age. So the weight loss comes as a management, because weight loss of 5 to 10% of total body weight has found to cause remission. So weight loss plays a major role in management. Also, we have to suggest a diet plan to the patient who was diagnosed with idiopathic intracranial hypertension. So next one is acetazolamide, that is carbonic anhydrase inhibitor, which decreases the CSF outflow because in IIH we have increased intracranial pressure. So acetazolamide decreases up to 50% of CSF protection. The major disadvantage of acetazolamide is it can cause a myopic shift in a patient. So we should be aware of if the patient is under medication or he is taking acetazolamide, we should be aware the patient might have a myopic shift. So next is topiramide, classically used for migraine prophylaxis. This medication is useful because it has a weak carbonic anhydrase activity and can lead to the weight loss. Again, the weight loss plays a major role in management. So diuretics, less effective at symptoms reduction than carbonic anhydrase inhibitor, which used with carbonic anhydrase inhibitor, it can lead to severe hypokalemia, which is a drawback. And the steroids can rapidly lower intracranial pressure. Caution is recommended as these can cause a weight gain. So we should be aware that when we are taking steroids, which can lead to the weight gain also. And rebound elevated in ICP is tapered off. So steroid therapy should only be in cases with severe vision loss or causes refractory to other medical treatments. Let's get into surgical management. We talked about lumbar puncture earlier, which relieves the symptoms of headache, and optic nerve sheath defenestration, which is a procedure where the slit in the dura or arachnoid posterior to the globe, leading to the increased outflow of CSF. So in pathophysiology, we saw that in a the cellular changes that the CSF outflow restriction or which causes the increased CSF outflow. So to increase the outflow, we can prefer the surgical management of optic nerve sheath fenestration and CSF diversion, which is also another surgery management, and lumbar puncture. Next one is a cerebral venous sinus stenting, which is also another surgical management procedure. So the differential diagnosis of PTC, pseudotumor cerebrae, that are cerebral venous sinus thrombosis, intracranial mass, obstructive hydrocephalus, jugular vein compression, superior vena cava syndrome, and decreased CSF absorption secondary to meningitis or following a subarachnoid hemorrhage and malignant hypertension. These are all the differential diagnoses for IIH. And next, I'm discussing about a case report. It is a management of idiopathic intracranial hypertension patient with chronic headache and visual disturbance. So this is a case of 45-year-old female with a 4 years history of headache and eye strain, also associated with head pain. So she was diagnosed with idiopathic intracranial hypertension. She came for a ophthalmic opinion. So the detailed examination and investigation revealed a mild bilateral astigmatism. So we will see the details in the further slides. And a significant visual field improvement and optic thinning. Yes. So the chief complaint of this patient is persistent headache and eye strain, also with head pain for 4 years. So the ophthalmic history is none, and systemic history, she's referred for fundus examination and visual field examination, and not aware of allergy. So on examination, the visual acuity is 6.9 in both eyes, and IOP is in right eye is 14 mmHg and 15 mmHg in left eye. So the subjective refraction is 0.75 at 20 axis, and left eye 0.75 at 170 axis. Color vision is 17/17, and EOM is full. There is no 6-nerve palsy or lateral rectus palsy in this case. So on slit lamp examination, normal, both the right and left eye have a similar finding. So since cornea, lens, and anterior chamber depth, everything is normal. And diagnostic findings are in fundus examination, we saw a mild pallor and pigmentary changes. And visual field testing, the visual field has improved compared to the previous report. And OCT thinning of the optic disc in right eye is seen in both the eyes. So the patient with the idiopathic intracranial hypertension should be idiopathic hypertension presents with a variety of ocular or neurological symptoms. So the regular monitoring with visual field testers and OCT is essential. A multidisciplinary approach is necessary for effective management. So this case highlights the importance of early diagnosis and comprehensive management and regular follow-up in patients with idiopathic intracranial hypertension to prevent a long-term complication. So we should be aware if a patient comes to the clinic with a severe headache, we should we should check the MRI report, and we should have a suspect of idiopathic intracranial hypertension with all these findings. So these are all my references. Thank you.
Thank you so much, Sandhya. That was a detailed presentation. Now I request our moderator for today and a pillar of support for the Optometry series, Ms. Meenakshi, to add her valuable points.
Thank you so much, Komati. Sandhya, it was a very wonderful presentation, and we are so happy that you brought something like, and it is so nice to see different cases brought by you. To first broadly describe about what is ICH, and to add how to differentiate ICH with glaucoma or papilledema, which is a common condition we see day in and day out. So ICH as such, it is nothing but an increased pressure within the skull. So in case of increased pressure, there are two broad classifications. Either it can be primary or secondary. Primary meaning there is no actual cause identified in case of primary ICH, but it is strongly associated with obesity. In case of secondary, it can be because of any brain tumors or infection that is taking place at the level of CSF, or it can be because of current medications like any antibiotics involving tetracyclines. With this case, as Sandhya explained, we know what are the signs or symptoms of ICH. To again summarize, it starts with a common, very persistent headache, which is very worse in the morning. Eventually, it slows down, but there will be a persistent headache. So during your history taking, common and persistent headache has to be documented. Common, what I mean here is that the headache will be starting as a common headache. Whenever we are stressed, whenever we are overloaded, we get some kind of headaches. It will mimic that kind of headache, but eventually it starts worsening up. And in the morning, it will be very severe. And as the day goes, it will subside slowly. This will be the common sign or the unique sign of ICH to diagnose or to keep it aside as a differential diagnosis. Followed by, we'll have visual disturbances where we get blurry vision or diplopic images. All patients will not report diplopic images, but in case of any disturbances of aneurysms or tumors, you get something called diplopic images, where the nerve fibers or nerve asset is getting involved. Then some patients rarely they wake up with blindness also. Yesterday I could see properly. Morning suddenly when I wake up, one eye is getting completely drifted out or it is completely becoming opaque. So that can also be one of the visual disturbances of ICH. Then we know clinically when we assess, we get something called papilledema. Papilledema is nothing but swelling of the optic disc, followed by other neurological signs or symptoms like vomiting, nausea with tinnitus. Tinnitus is commonly associated because pituitary. In that case, it will have hearing loss or any changes in endocrine functions. To clinically diagnose what is ICH, glaucoma or papilledema, clinical evaluations is very, very important, starting from a proper history taking. So while history taking itself, you can document it is a persistent morning headache, which is very, very severe in the morning, followed by any association of obesity. And if the patient is taking any medications associated with antibiotics, has to be documented. Then going into a clinical examination, papilledema or continue with when we do something called clinical examination like fundus examination, we should check for papilledema, very common as sign of any kind of increased or elevated cranial pressures. And along with that, since because of optic nerve it is getting involved, there will be obvious visual field changes also. So enlargement of blind spot will be seen. When you go for OCT assessment, since because we have changes in the nerve fiber layer, if you do OCT assessment here, thickening of your nerve fiber layer will be seen. Whereas that is ulta in case of glaucoma. You will have an cup-disc ratio getting enlarged and thinning of your nerve fiber layer. So blind spot, enlargement of blind spot can be a common symptom for glaucoma and ICH. In ICS, there will be thickening of nerve fiber layer in retina. Whereas in case of glaucoma, it is thinning of your RNFL layers in the retina. So that can be a common sign which we can differentiate between glaucoma and ICH. Along with the fundus examinations or visual field changes OCT, we should also do something called neuroimaging test, which will help us to rule out any kind of tumors or aneurysm, any kind of hydrocephalus in the brains, or changes in case of structural abnormalities. But neuroimaging can be very, very normal in case of idiopathic ICH. But in case of it is normal, we'll have a unique sign called as empty cellar syndrome. Nothing but the pituitary gland extension will be very shrunken or flattened. So that particular sign, if you see, it can be associated with obesity, and we can conclude stating that it is an idiopathic intracranial hypertension. Only in case of idiopathic, the MRI or any kind of neuroimaging will show completely normal assessment, but you can see an empty cellar syndrome alone. Again, what is empty cellar syndrome? It is nothing but a shrunken or flattened pituitary gland. Finally, we'll also go with the checkup of your CSF pressure using lumbar puncture. That can give you the values of CSF as such. As Sandhya mentioned, the values can be more than 200. It can be more than 250 also sometimes. Then CSF analysis has to be done to rule out any infections in CSF, followed by all the final conclusions of or ruling out of differential diagnosis. This can help us diagnose what is ICH as such. So what is the optometric management? How can an optom find out what is ICH? How can an optom intervene or completely refer? It is an ICF case, and it has to be referred. So in case of optometry point of view, I would say that history taking is very mandatory, followed by any kind of clinical evaluation like changes in visual problems or disturbances, blurry vision or diplopia changes can be occur. Fundus examination has to be done to rule out papilledema, followed by visual field assessment and OCT. This all together can give you an idea. It can be an intracranial hypertension, be it idiopathic or be it a secondary intracranial hypertension. In that case, you can refer them for neuroimaging. After imaging test, if it is in secondary, you will see some changes in the brain, structural or change in the enlargement of herniations can be seen. In case of idiopathic, you will see empty cellar syndrome. This can be a possible optom point of view. This can be an optom point of view. And if you don't do as an early intervention, what will it occur? Sometimes because of a constant increase in pressure in CSF, brain tissues can be irritated. In that case, seizures are very common. And if it is idiopathic again, your pituitary gland is getting flattened or shrunken. In that case, endocrine dysfunctions or hearing loss can occur. Finally, it might lead to some irreversible changes in the nerve tissues of brain. So that is why early intervention and involvement as an optom is very, very necessary.
Full explanation from your side. I'd like to thank Ms. Sandhya also for a wonderful presentation. Thank you guys. If you like this video, give a thumbs up and share the video with your friends. If you have any doubts, please post your questions in the comment box. We'll get back to you with the answers. The announcement for the day is the admissions are open for bachelor's, master's, fellowship and internship in optometry at Dr. Agarwal's Institute of Optometry. If you want to apply, please refer to the contact number that is provided in the description box. Meet you all in the next episode. Thank you so much. Thank you, Meenakshi.